You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
When every decision matters, you need trusted medical intelligence. Medscape AI synthesizes peer-reviewed evidence and Medscape's expert-validated content in seconds, delivering clinically verified answers you can trust. Join over 13 million Medscape members on the world's leading platform for clinicians. Start using Medscape AI on the web or in the Medscape app. Medscape AI, trusted medical intelligence.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for August 14th, 2026. This week, a trip down under, listener feedback, the ZEUS trial fails, a fascinating statin trial, more on GLP-1 drugs, and radiation safety in the EP lab. The first thing to say is to thank many people. Thank you to the organizers of the Cardiology Society of Australia and New Zealand for the invitation and amazing hospitality in Sydney. Meeting attendance there was impressive. The venue was clean and spacious, the program fantastic, and my gosh, Sydney is gorgeous. I took a 10K run on Saturday morning along the bay by the Opera House, and there were hundreds of people to run with on that sunny, cool morning, and this may have been my best city run ever. I got to debate against coronary calcium scans, and it turns out that in Australia, like Denmark, the scans are used for their intended purpose, which is refinement of risk stratification, as opposed to their American use, which is to scare patients into having stress test, angiograms, PCI, and cabbage, aka otherwise known as cash machines for hospitals and doctors. I also debated Prash Sanders, and the title was Everybody Deserves a Shot at Sinus Rhythm. Obviously, there are patients we would not try rhythm control on, so I had the edge in this debate. The debate discussant, Pat Prash's friend, Professor John Cowman, called it a draw. Now, one thing I learned from Prash and others is that there is a lot of undertreatment of AFib in Australia. I gave my talk on critical appraisal of trials, and I got to speak with fellows as well, and in the closing ceremony, EP trainee Catherine Bate and I recapped four hot topics in EP. Then I hopped on a plane to Adelaide, South Australia to visit the group of Prash Sanders. The first day I watched cases in his lab, and then I gave an AFib talk that evening. The next day, I heard from about 10 of his 20 PhD students present their projects, and my gosh, what an impressive group of young people doing serious research on important topics in cardiology. Now, I knew that Prash had an impressive research enterprise, but seeing it firsthand was really stunning. If I were a young person looking to make a name in research, I'd be calling Professor Prash Sanders. Then there was the bike ride. Anthony, Mark, Jackson, and Nicola took me into the Adelaide Hills on many of the roads from the tour down under. Everything about this ride was thrilling. I could hang pretty well on the flat, somewhat okay on the uphill terrain, but I had zero chance to follow these maniacs on the harrowing descents, on the wrong side of the road, by the way. Oh, and by the way, the brakes on bikes in Australia are mixed up. The left shifter goes to the rear brake and the right goes to the front, and I was talking to myself the whole ride, John, don't grab the right brake, you will die. I was late for dinner that night because I fell stone asleep sitting in the chair in my hotel. Thanks again to the many listeners in Australia and New Zealand. I appreciate you all so much. Okay, now some quick listener feedback. Dr. Gwym Morris, an EP in Newcastle, Australia, wrote about my coverage of the failure of posterior wall isolation to improve matters over basic PVI and AF ablation. He writes, in addition to the negative trials you discussed, the mechanistic contribution is mainly unproven conjecture. The principal basis for this assertion is that the accepted wisdom is the posterior left atrial wall shares a unique embryonic signature with the pulmonary veins, which is not present in the remainder of the left atrium. However, Dr. Morris says this does not definitively stand up to scrutiny. What did he do? Well, he looked. The ubiquitous introductory sentence in these ablation trials is along the lines of, quote, the left atrial posterior wall shares an embryonic origin with the pulmonary veins. But if you follow the references for this statement backwards, they almost universally reference another paper that contains no supportive data, just the same statement. Following this trail even further back often finds a dead end with no source data regarding the embryology of the atria. By the way, this is common where things get passed down in the literature. Dr. Morris writes that much of the knowledge of atrial development comes from the study of chick embryos, so translatability is questionable. He writes the most recent study of 26 human embryos concluded that the incorporated venous tissue includes the left atrial posterior wall, but also much of the interatrial septum and is fully atrialized, unlike the PV sleeves. But he writes that I would concede, however, that the strategy of posterior wall isolation is not disproven, it's simply not yet proven. All of the posterior wall isolation trials are underpowered to detect any additional benefit. For example, the CAPLA data shows AFib-AT freedom of 53% in the PV-only arm, meaning that only 47% of patients could potentially show benefit from additional ablation. So that to detect the difference with reasonable recruitment targets, we would need a difficult study that recruits patients who have AFib recurrence and durably isolated PVs. I would randomize to no further ablation versus additional posterior wall isolation, and that power calculation would be for a lot more patients to be included. I thank Dr. Morris for his message, and I learned a ton from these messages, so keep them coming. All right, the first topic today is that the ZEUS trial fails. While I was in Australia, Novo Nordisk announced the failure of the ZEUS trial of the IL-6 blocking drug ziltivekimab to reach its primary MACE endpoint. It's such a big story that I wrote a column on it on Medscape called The 4 Lessons from the Trial Regarding Inflammation and ASCVD. Take a look at that written column. So ZEUS was a CV outcomes trial of the drug ziltivekimab, which is an investigational, fully human monoclonal antibody that targets the IL-6 ligand, which is a pro-inflammatory cytokine. The trial enrolled high-risk patients who had 3 features: established vascular disease, high sensitivity CRP, and CKD. The drug markedly and significantly reduced levels of IL-6 and CRP, but it had no effect on MI, stroke, and death primary endpoint. Hazard ratio 0.99 with confidence intervals pretty tight, 0.88 to 1.11. I hope you read my article, but in it, I laid out the pre-trial idea that inflammation seems to have a causal role in ASCVD. There's pathologic data, epidemiologic data, and there's therapeutic studies. In fact, there's 2 colchicine trials and 1 trial with canakinumab, which showed modest benefits. But on the other hand, another colchicine trial and a methotrexate trial were both negative. So the 4 lessons I found from the data, briefly, were that ASCVD and inflammation are likely too complicated for a focal blocker of one pathway to impact outcomes. 2, plausibility is never enough in medicine, and I cannot emphasize this enough. We need to show that a reasonable idea reduces outcomes, not a surrogate marker such as CRP levels or LDL levels. And 3, perhaps we were wrong about the causal link between inflammation and ASCVD. Clearly, there are diseases that are inflammatory, and many of them are improved by anti-inflammatory drugs. Take rheumatoid arthritis, for instance. Finally, drug development is hard, and I think us doctors are shielded by the struggle. I mean, we see this success at our late-breaking sessions, or we see it in journals, but for every one of these successes are many that fail. And I actually think that our great success in modern cardiology is going to make it even harder for new drugs to make an incremental difference. And here I am looking specifically at those lipoprotein(a) drugs. All right, next topic is statins and the elderly. The Lancet journal called Lancet Health Longevity has published a very interesting French non-inferiority RCT of, get this, statin discontinuation in adults aged 75 years and greater. The question is that while statins are definitely the most evidence-based therapy in all of medicine, most of these trials enrolled younger patients, median age like high 50s. Most of the seminal primary prevention trials excluded patients over the age of 75, and guidelines, therefore, rightly, I think, give statins in older adults a weaker recommendation. And there have been really no substantial discontinuation trials in older adults. So this was a multi-center French trial conducted in primary care offices where about 1,160 patients without known ASCVD, median age 80, 67% women who had been on statin for more than a year were randomized to discontinuation or continuation. Now, these patients had substantial comorbidity. A third had diabetes, 3/4 had hypertension, 2/3 had high ASCVD risk. Excluded were patients who had dementia, familial hyperlipidemia, or any other progressive disease that would limit longevity. The design was non-inferiority with a margin of 5% absolute risk difference in 3-year mortality, and it was based on an expected death rate of 15%. And this whole non-inferiority margin and expected rate are going to come back. I'll come back to it, but put it into your memory bank. So the results, as expected, the LDL cholesterol rose substantially after discontinuation. It went from 114 to 170 milligrams per deciliter. All-cause mortality at 3 years was 7.9% in the continuation arm versus 7.2% in a discontinuation arm. The absolute risk of decrease was minus 0.68%, and the confidence intervals went from minus 3.9 to 2.6 in absolute risk difference terms. Non-inferiority was declared since the upper bound of the confidence interval stayed below 5%. That is, 2.6 is less than 5%. Now, the hazard ratio, if we were looking at relative risk, was 0.88 with 95% confidence interval 0.57 to 1.37, and I'll come back to that. Cardiovascular events were numerically higher with discontinuation. For instance, the MACE was 4.4 versus 5.0, stroke 1.9 versus 2.7, but these small differences did not reach statistical significance. Obviously, these are underpowered comparisons. There was no difference in quality of life between groups, and I did not see any notable heterogeneity in the effect when I looked at the subgroup plots. The authors concluded that discontinuation of statins was non-inferior to continuation in terms of all-cause mortality over 3 years. Quote, "These findings support individualized decision-making regarding statin discontinuation in older adults." They also add in the discussion, quote, "Our findings represent a major step forward in the management of older persons with respect to cardiovascular risk," end quote. So my comments. This is an intensely interesting study. I mean, let's start with how cool it was that it was conceived and conducted in real-world practice. I mean, millions of older adults take statins, some until death for other causes. And I like to say that primary prevention therapies are given to 50 and 60-year-olds so that they get to be 80 or 90, and once 80 or 90, the benefit is less. They've graduated from that, for instance. This trial tests that thesis, and it holds up pretty well. Now, why is it different treating the elderly with statins? I mean, you have to think of Andrew Foy's 4 circles of domains that act on treatment effect. 2 opposing circles are the treatment benefit versus risk of harm. The other 2 domains are the risk of the primary outcome, which is here is an ASCVD event, versus the competing risks, such as dementia, falls, pneumonias. Lots of things could happen to older adults. Consider a 55-year-old who's post-MI, diabetes, and no other conditions. This patient is ideal for statins. Right? He has a high risk of a cardiac event, a low risk of a competing event, and would get a large treatment benefit. But compare that to an 85-year-old who they may have a high risk of a cardiac event, but they also have a high competing risk of non-cardiac events, and the calculus is different. That patient who's older may have a risk of liver or muscle toxicity due to drug-drug interactions as well, so there may be more treatment harm. Perhaps most importantly, an 85-year-old may have different preferences. That person may prefer taking less trips to the pharmacy, and he may be more worried about dementia or a fall than a non-fatal MI. All right, now let me discuss the results. The discontinuation did not lead to higher death rates. In fact, it was 12% lower. CV event rates were hardly increased, 4.4 versus 5.0, and that 0.6% risk increase is tiny, and it could just be noise. So the authors comment that A, it was non-inferior, and B, supported individual decision-making, is somewhat reasonable. Now, I add the somewhat modifier because individual decision-making is always correct, no matter the results of the study. I mean, even if the death rates were higher in a discontinuation arm, patients, especially older ones, could still rationally say they don't care and don't want your pill, and that is fine. And this is a tenet of evidence-based medicine. Now to the guts of the data, because I don't think the authors have it quite right. The non-inferiority margin of 5% was based on a controlled death rate of 15%. That would mean, in relative terms, the non-inferiority margin would be set at 1.33, right? 15 plus 5 divided by 15, 1.33, and that's probably okay. 33% is a little high, but then, okay, we can argue about that. But then in the trial, event rates come in at 7.8%. So 5% is proportionally much more lenient at 7.8% than it is at 15%. So the absolute risk difference of about minus 0.7% has an upper bound of 2.6%, and that allows the authors to declare non-inferiority. But, if they used relative risk, a more stringent test of non-inferiority, when observed event rates are lower than expected, the hazard ratio is 0.8, but the upper bound is 1.37, which would be higher than 1.33 if you calculated that from the 5% non-inferiority margin at 15%. So, like the Champion AF and option trials, if the relative risk were used, the effect does not meet non-inferiority. Now, another way to state this is that if you use a 5% absolute risk increase as the non-inferiority margin, for a control event rate of 7.9%, you'd allow an upper bound to be 1.66, or 2/3 worse, and that's way too high for a mortality bound. So the trial, if it was properly reported, would read statin discontinuation is not non-inferior to statin continuation. Now, whether that changes the interpretation is debatable, but we should be technically accurate, and when we do non-inferiority trials, non-inferiority should be met in relative terms and in absolute terms. Okay, now I want to state what the statin proponents would say. They would say the trial is underpowered. Given the lower than expected event rates, you'd want more events to have tighter confidence intervals. The spread on the 0.88 hazard ratio goes from a 43% benefit to a 37% worsening of death, and in other words, it's largely uninformative. Proponents would also say that 3 years is too short a follow-up, as statin drugs exert their influence over many years. And had the trial gone longer, there may have been higher events in the higher LDL or discontinuation group. Though I have to say, I find 3 years of follow-up in a trial with 80-year-olds quite impressive, actually. Proponents of statins in the elderly might also say that the trends in MACE favored continuation, which is true technically, but if the main endpoint is uninformative because of underpowered, surely the single event rates are even less powered to make any conclusions. Now, another issue is that this contradicts large observational cohorts in other countries that have reported about 30% higher risk with statin discontinuation. Now, I don't worry too much about that because observational studies are going to be limited by selection bias. Obviously, patients who are sicker could be stopping the statin, and that's what contributes to higher event rates. Finally, the trial may have recruited patients that doctors felt were healthy enough to stop their statins. Though I have to say the median ASCVD risk of these patients was high. The risk scores are based mostly on age. I also don't worry too much about this potential selection issue because there are oodles of patients like these who take statins into their 80s and they seem pretty healthy without any known ASCVD. So I actually think this is a pretty representative population of older people. Now, my final comment would be that the claim of non-inferior for discontinuation was incorrect given the lack of testing with relative risk scales. And while the trial was underpowered, there is a signal that discontinuation of statins may be achieved in selected patients without substantially increasing risk. I would emphasize may be achieved, and I would say for this trial to influence practice, it should be reconfirmed in other similar trials. This is a bold effort, and it should encourage more discontinuation trials. And we should hold this data not against a massive statin evidence base for statin benefit, as the trials that showed statin benefits were conducted in young people, but rather we should compare these results against a very tiny evidence base in the elderly, who have a very different ratio of primary event to competing events than, say, young people. I say good on the French team. Now it's up to others to perform similar trials. My prediction is that there will not be a signal of harm in stopping statins in patients in their 80s and 90s, but we need more data, and this should stimulate us to do more of these discontinuation trials. All right, next topic is GLP-1 drugs and CV risk. Jack has published a post hoc analysis of the SURMOUNT-1 trial, which is tirzepatide versus placebo in patients with obesity. The paper looked at biomarkers of inflammation and cardiometabolic health. Now remember that SURMOUNT-1 was published in New England in 2022, and it showed that tirzepatide induced a dose-dependent weight loss in patients who had a mean BMI of 38. Now, this new paper is mostly descriptive, and it's not too sexy, but it points to something I want to say about the GLP-1 drugs. Before I tell you about the post-hoc study on biomarkers, let's first remind ourselves that not only did tirzepatide reduce weight in SURMOUNT-1, the study also showed reductions in systolic blood pressure, insulin resistance, total cholesterol, LDL cholesterol, and triglycerides. In the post-hoc study that's in JACC, at week 72, the 15 milligram dose of tirzepatide was associated with a 55% reduction in CRP, a 30% reduction in IL-6, a 40% reduction in insulin resistance, 61% reduction in leptin, 40% reduction in gamma-glutamyl transferase, and a 40% reduction in fibroblast growth factor 21. A 48% reduction in adenopectin, and there was more, but I don't exactly know what all they do, but you get the message that this drug is reducing important inflammatory and cardiometabolic biomarkers. My point in highlighting this is similar to the point made by editor-in-chief Harlan Krumholz in his column. That is that these drugs should not be considered weight loss drugs, but cardiometabolic health drugs. I, like you, have already seen middle-aged adults drop their calculated ASCVD risk dramatically, and this could have a massive individual and societal benefit. For instance, a 55-year-old with obesity, type 2 diabetes, hypertension, poor mobility is facing a shorter and less healthy life. These drugs could largely improve that outlook. Yes, of course, I know it's possible to achieve the same risk reductions with diet and exercise and living in Oslo, Norway, but Americans in the southeastern United States do not live in Oslo, and Atlanta, Louisville, Nashville, these places are never going to be Oslo. I strongly believe that these drugs, GLP-1s, will have a dramatic effect on average when used in appropriate patients, and I predict this benefit is going to far outdo statins in the disease modification category. Yes, I also know there can be side effects, and these side effects will counter their use in lower-risk people. But for the millions of Americans who are destined to live shorter, less healthy lives, these drugs could provide a huge benefit. I am also predicting that these could end up being our next big breakthrough in AFib care. My enthusiasm, though, should not be translated to patients with HFrEF. I worry there is a signal of harm in these patients as the heart rate is clearly increased with these drugs. I'm also very worried about committing children and adolescents to these drugs because here we have a much better chance to move cardiometabolic health with lifestyle. While we aren't going to transform our kids into Norwegians, I see a public health emergency in childhood physical education. If I was a public health official, I would spend 95% of my time trying to improve the physical education of children. All right, next topic is radiation exposure to the uterus in the EP lab. Dr. Johanna Müller-Lessy and colleagues from Hanover Heart Rhythm Center in Germany have published a nice research report in Circulation where they have studied radiation exposure to the uterus in a typical EP lab. I covered this report because we need more women in electrophysiology, and radiation exposure, especially during pregnancy, is a big deal. I also cover the paper because it's pretty neat. They simulated a pregnant physician scenario by having the primary operator wear a continuously active electronic personal dosimeter, an EPD device, under the lead apron at uterine level during all catheterization lab procedures. A second reference EPD was kept in the control room. Measurements ran continuously from January 2024 to August 2025 and used 2 consecutive 40-week periods, which would match, of course, a full-term pregnancy length, and that was done to improve reproducibility. Environmental dosimeters in the control room and nearby offices tracked background radiation separately. They had 505 ablations, 183 device implants across 8 physicians. And after subtracting background radiation, the net cumulative uterine dose was 0.037 millisieverts, far below the regulatory limits of 1 millisievert in Europe and 5 millisieverts in the U.S. The authors concluded that occupational radiation exposure to the uterus during a simulated pregnancy of daily EP work remained well under legal limits, offering reassurance for women considering continuing interventional training during pregnancy. So my comments. I think this is a nice data where they measure the occupational increment attributable specifically to performing procedures with the ambient natural background radiation stripped out. Now, it ends up being very low, and as they write, it is reassuring. But I would note in Hanover, they had pretty low fluoro times for ablation and procedures, and they also used a low-power fluoroscopy setting, and my old eyes likes the higher-powered X-ray setting. So just keep in mind that their data doesn't necessarily translate to you if you're on that radiation pedal all the time. But the data is reassuring because the exposure is so low. But as they note in the paper, as a limitation, the fetal dose was not directly measured, and it depends on factors such as maternal body habitus, although they did have conservative margins. To be honest, I do worry a little bit about radiation from our profession. I figure that I am a goner because it was really bad back in the 1990s. I mean, X-ray exposure right now is a lot better. But an EP doctor gets more radiation than a dermatologist or a primary care doctor. So it has to be figured in the choice of profession. I appreciate this work and I commend the Hanover team for doing it. Dr. Muriel Lassie is also interested in the compatibility of the cardiology world with family concerns. And to this end, she has a short survey, which is only 3 minutes, that I wanted to share. I'm going to link to the survey in the references, and I would recommend that you help her out, and this will help her sort out the family compatibility issues in our field. And it's notable because it was easy on me because I had Stacy, my wife, who sacrificed a lot in her career for me. That's not a luxury that many young women have. So this is important research, and do her survey. Finally, a brief preview of next week. This is on cannabis and arrhythmia. The team of Dr. Greg Marcus is at it again studying interesting things. This is the UCSF group that infused alcohol during EP studies and showed that alcohol causes proarrhythmic changes in the atrium. They also famously showed in an RCT that coffee may have protective effects in arrhythmia. Now they have studied ectopy and cannabis use. I will cover this JACC paper next week. Take a look at it in the meantime. There are some nuances to discuss about this paper. And so that's it for this week in cardiology. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.